Dr. Rhoda Olkin is a distinguished professor of clinical psychology at the California School of Professional Psychology at Alliant International University. As a polio survivor, she brings lived experience, teaching, and research to bear on best practices in teaching about disability as part of diversity. She is the developer of disability affirmative therapy, a consultant on legal cases related to disability, and a disability rights advocate within psychology. Dr. Olkin is the author of 3 books on the intersection of disability studies and clinical and counseling psychology: Teaching Disability, Practical Activities for in Class and Homework. So disability affirmative therapy, a case formulation approach for your clients with disabilities, and what psychotherapists should know about disability. She is a mom to 2 children and 1 cat and lives in the San Francisco East Bay area. Dr. Olkin, we are so incredibly honored and thrilled to have you join us here today. And at this point, the floor is yours.
Thank you so much, Daniel. I apologize in advance that I'm going to be blowing my nose throughout this. There's bad allergies this year. I'm going to be talking about how to teach about disability as part of diversity. So as Daniel mentioned, I did have polio. I was 1 year old. It was just before the vaccine was available in the country. And so my life's purpose was really about making the world a better place for people with disabilities. And then that was just a little bit large. So I set my sights on just the US, and then that was a little large. So then I set my sights just on clinical psychology. And ultimately, I got it down to just my program within my university. Um, but what I've been trying to do is to really integrate disability studies with clinical psychology. So, disability studies started in England and it was very interdisciplinary. It adopted the social model of disability and it's very non pathologizing. It just sees disability as a part of human diversity. But the interesting thing is that even though it was interdisciplinary, it really did not include psychology, much less clinical psychology. And in psychology, it's a very pathologizing model. We learn about disability as part of assessment. How do you assess for various different kinds of cognitive issues, for example, or learning disabilities? You learn about autism in an abnormal psychology class. It adopts the medical model. It views disability as an abnormality, and it often studies disability as if that's the sole defining demographic of the person and ignores everything else. So, what I've been trying to do is bring disability studies into clinical psychology. So, the agenda for today, I'm going to talk a little about what we know already and then look at some data that clients have told us about their experiences in clinical settings, talk about the goals of teaching about disability, and then I'm going to give 3 examples of activities I've used from the beginning level and intermediate level and a more advanced level, and talk about some of the outcomes that I have found when I teach about disability, show you a few measures that you could possibly use, and then some final parting words. So first, what we know is attitudes towards disability is one of the most studied topics within disability. And there are just thousands of studies on attitudes towards disability, and they almost always show negative attitudes. Interestingly, despite the wealth of studies on attitudes, there are very few on psychologists, clinical counselors, even anyone who's in any of the clinical fields. And we wouldn't expect to find very different results looking at psychologists than we would for any other field. And we have to think about what we want our students to have when we teach them about disability. We need them to have some relevant knowledge, and most people just have no exposure to some basic knowledge about disabilities. We also need them to have skills that are disability culturally appropriate. And then we need them to manage their own countertransference toward disability. So there's very little or even sometimes a negative correlation between implicit and explicit bias towards disability. And that's important because it suggests that when we teach about disability, we want to affect implicit bias because that's one of the things that becomes manifest in a therapy setting in some unconscious ways, slightly stumbling over a word, being hesitant to talk about disability, not knowing how to bring it up. So just affecting explicit bias is probably not going to be sufficient. There was a study in the United States on changes in explicit and implicit bias over a 10-year period. And for most of the conditions, there were changes that went from negative towards a more neutral implicit bias for 6 different groups, including sexual orientation, race, and skin tone. But the implicit bias towards disability was stable over that time period and remained negative. And in that study, the weakest correlation between explicit and implicit bias was found for both disability and age. And again, this implies that when we teach about disability, we have to try to affect implicit bias. Now, we know that clients with disabilities in general have a higher risk for some mental health issues. This is not true equally for all disabilities, but is true across a wide variety of disabilities. So, one of the reasons for that is that there are higher rates of physical and sexual abuse of children with disabilities compared to non disabled children, over 2 times the rate, which is really important to know about because that means clinically, often we're treating somebody not just with a disability, but also with some history of trauma, and we can't overlook the trauma background. Secondly, for some disabilities, you're going to see higher rates of substance use disorders, and there are a couple of reasons for that. One is using substances can lead to disability, for example, drunk driving. And secondly, there are pain medications that are the kinds of medications that are more prone to misuse than other kinds of medications. Then there are medication complications and a history of negative medical experiences, which people bring into the therapy with them. So you may be seen as part of a medical establishment and therefore initially viewed negatively. And like every minority, people with disabilities experience microaggressions, stigma, and discrimination on an almost daily basis. For some disabilities, there's a higher likelihood of certain coexisting mental health disorders, and in particular, PTSD, depression, and anxiety. And because a lot of disabilities have some pain component, pain is a big factor in people's well being. And then, as I'll talk about later, fatigue is a byproduct of a lot of disabilities and it interferes with activities of daily living. And when that happens, people sometimes get depressed. So we have higher risk and elements that we have to be aware of that are in addition to the disability that we don't want to overlook. Now, there are lots of differences across different disabilities. They're different in terms of how visible or concealable they are, the aesthetic qualities, what people assume is the actual origin or cause of the disability, whether it's something that's life-threatening, that if it's something that's going to get worse, or something that's relatively stable. and what's the degree of uncertainty or uncontrollability of the disability. So an example might be something like multiple sclerosis, where when you get the initial diagnosis, you're told, let's wait 5 years and see how it goes, where it's a very unpredictable prognosis and people have to live with that uncertainty. The degree to which any disability interferes with communication, and then perceived peril to others, whether other people feel as if it is contagious, even when it clearly isn't. And so, a key question is, given all of these differences, when we teach about disability, can we impact attitudes about disability globally without addressing each of these differences? So when we teach, are we teaching about disability as if it's some big monolithic thing? Or do we have to think about different categories of disabilities and direct our teaching towards those different categories? This is an empirical question that I don't have the answer to. So, what have we learned from clients with disabilities? There are really only two studies that look directly at general clients, not going to any rehab setting, not going to anyone who specializes in disability, but just general therapists. Um, and one of them was with 62 people with physical or visual disabilities, and they completed a survey about their psychotherapy experiences. And we had 4 questions. What were your best and worst experiences in psychotherapy? To what extent did you perceive your therapist to be knowledgeable about disability and disability affirmative therapy? What issues led you to seek therapy, and were they disability related or directly about the disability? And what were the barriers to treatment? We had 50 responses about the best experiences, and 22% were directly related to the disability, such as, she wanted to know about my disability and why I feel the way I do and listen to what I said. Or, I was taught techniques to manage my pain, which included relaxation and breathing exercises. Or, many breakthroughs regarding how my disability affects me and how to deal with those limitations given my prognosis. So hold on to that number for a minute. 22% of the best experiences were about their disability, but 41% of the negative worst experiences were directly related to the disability. So examples were the therapist not getting the complexity of having a disability and how it affects your life in every aspect. Or the therapist seemed to center her focus on my child's father rather than me, giving him more credit for being the non-disabled parent. Or the therapist asked a bunch of questions about my blindness, and it came off as that of pity and curiosity and not of a therapist. So more of the worst experiences were directly related to disability than the best experiences. So how did these 62 respondents think about their therapist? They thought that their therapist was mostly knowledgeable about stress management, but they were not as knowledgeable about either fatigue or pain management, which are two of the biggest things that occur for people with disabilities. Only 11% said the therapist raised the topic of disability first. And interestingly, that was true despite the fact that 82% said that disability was one of the main reasons for seeking therapy. We found expected barriers to treatment. One was the cost of therapy, and people with disabilities are much more likely to have government insurance than private insurance. And there are lots of therapists who don't take let's say Medicare, and non-acceptance of Medicare was a big issue. Those with vision impairments reported the most barriers, starting with websites and then intake forms and all kinds of other forms. Only 30%, 37% had curb cuts to get to their office. Only about half had accessible restrooms. So all of this informs how we want to teach about disability. So what are we trying to do? We're trying to reduce both explicit and implicit bias towards disability. Then we're going to try to accurately assess those changes in bias. And we're going to need to do short-term follow-up as well as long-term follow-up, because there's often a change from what people say immediately after to what they say 3 to 6 months after. And then, very importantly, we want to have those changes be reflected in their clinical approaches with disabled clients. So this is a big undertaking. And most diversity classes have a whole host of things they have to cover. And often disability is a 3-hour class. You can't possibly do this in a 3-hour class. It's hard enough when I'm given a 45-hour class to teach specifically about disability. So maybe what we can hope for in a 3-hour class is to teach students what they don't know. That is, you don't know what you don't know. And so if we can talk about some of the topics related to disability, at least it tells you that this is a very big topic and that there's much, much more that you need to know. But we're probably not going to be able to change people's skill level in meeting with clients with disabilities. We have a lot of teaching options, and we probably have to use all of them. So textbooks, disability affirmative therapy is the one I wrote for clinicians. Biographies written by people with disabilities, about people with disabilities, disability affirmative therapy, documentaries and YouTube's first-person lived experience accounts are one of the more powerful ways that students talk about. And then there are fictional movies, but you need to use fictional movies in a particular way. If you just have someone watch a movie, they don't necessarily pick up the things in the movie that you want them to notice. And so, for example, I use My Left Foot. And then I have students read an article about the real person who was depicted in the movie My Left Foot and have them do a comparison. What did the movie leave out? What did it show more of? And then what are some things that you notice about the film that seem important? So, for example, a number of movies show the importance of a parent as an advocate, saying things like, I want my child in a regular classroom. Just because my child's disabled doesn't mean they can't learn. But the other thing is that Hollywood has often very cheery endings. The real life of the man in My Left Foot did not have a cheery ending. He was possibly murdered by his personal assistant. And so we start to talk about how disability is depicted in the media. So it's not enough to just say, watch this film. You have to really have some talking points around the film, or people don't necessarily notice some of the intricacies. The other intricacy in movies is that often the role of the person with a disability is played by somebody without a disability, which is very important to notice. And secondly, that their role in the movie is to make other people more aware and better people. It's as if we're put on earth to help you be better people. Then I often have them interview a person with a disability. What is that person's lived experience? And we use the respectful model so that they go over all different aspects of diversity. Don't just focus on the disability, but disability in the context of every other demographic around the person. I assign them when I'm teaching it for a 15-week class. I assign them a disability at the beginning of the class, and they have that for the rest of the class for various assignments. And so I'll have them go research their own assigned disability. And if by chance I give them a disability too related to the one they actually have, I give them something else. And then I have them consider that assigned disability in the context of who they are. And I'll talk more about that in a little bit. And I have them respond every week to vignettes of clients with disabilities, and I have them answer some specific questions around those vignettes. And that's one of the ways I'm trying to assess their skill level, not just their attitudes. So one of the things we should not use when we're teaching about disability is simulation. There's a reason for that. Acting disabled is not the same as being disabled. Secondly, disabled people develop experience and skills. So putting on a blindfold does not in any way mimic what it is like to be blind, because when you're blind, your brain starts to make accommodations from the get-go that you now use in ways that somebody with a blindfold on wouldn't have. Secondly, it places the emphasis on the physical aspects of the disability. And when you ask non-disabled people, what do you think is hard about having a disability? They do point to the physical aspects. But when you ask disabled people, what's the hardest part of having a disability? They say other people. In other words, it's the interpersonal psychosocial aspects, the systemic barriers that they point to, not the physical aspects generally. It also implies that the only way we can learn about disability is through direct experience. And if this were true, how would we teach diversity classes? How would we teach about race? How would we teach about being LGBTQ if we thought you have to mimic that? And mimicking is rude. We don't ask this about any other group. We don't say, go out and pretend to be gay for a day. We only seem to do that around disability. And lastly, the studies on simulation, studies on simulation suggest that in the short term, people say, oh, it was really exciting. I got really involved. It was so great. I learned a lot. People are enthusiastic and they say, I have more empathy now. But the long-term consequences is that it increases pity and it focuses on what people with disabilities cannot do. So all those are good reasons not to use simulation. And having said that, there is one way I do use simulation. If I have a person with a visible disability in a class, I send the entire class out to a public place with the person with the disability. And then I have the whole class observe how the public interacts with that person with a disability. So nobody's pretending to have a disability, but we're using the reality of a disability to show how the world reacts to disability in a public milieu. So I wrote about how to teach about disability. And for every activity, I have 36 activities. I tried to give diversity instructors everything they might need to do a class on disability. because I assume that someone's picked to teach a diversity class because they have lived experience with one aspect of diversity. And we simply cannot assume that a teacher of a diversity class is familiar with all aspects of diversity. So I'm really assuming that the person probably doesn't have lived experience with disability. So I'm trying to help them teach by giving them what I hope they need to teach a particular activity. So I tell them what the activity is and then where to do it. Is it out in public? Is it a classroom thing? Is it online? And what is the purpose? What are we trying to get out of this activity? And learning objectives. Then what are the materials you need? And if you need, say, a tracker, I put the tracker in the book. And is there preparation? So, for example, if you're going to assign a movie, do you need to do any talking about the movie before they watch the movie? Do you need to have a list of questions they might think about as they watch the movie? Or are they ready to be sent out to do the activity? How much time does the activity take? And what are some of the possible outcomes, both positive and negative, that you might have to talk about when you go over how did this activity go? So, what are some talking points you might think about? If you want, there's a grading rubric, and then all of the handouts, as well as at least 3 to 5 additional reading related directly to that activity. So I'm going to go over 3 different activities. I'm going to pause after each one to give you a chance to ask any questions about anything we've gone over so far. So a very beginning level activity is trying to teach about intersectionality. And I call it intersectionality 1 because I have a much more advanced assignment around intersectionality as well. So each student in the class is assigned a disability that's not their own disability if they have one. And I give them these instructions. You're a person with various demographic characteristics, such as gender, sexual orientation, race, ethnicity, national origin, religion, age, and socioeconomic status. For this assignment, you will be researching your assigned disability using your own demographic characteristics. What can you find on your disability as it intersects with your other features? Then, what can you find about intersectionality, your disability, and all of your features at once? Use the form and come to class prepared to discuss what you have learned. And then I would go over this form with them, and maybe we would do me as an example in the class. So we would put what is my gender and what is my race, etc. So we'd fill this out. And then what do we find? So I had polio. So we would look at what can we find about women with polio versus men with polio. Okay, now what can we find about my being white and polio versus other nationalities or races or ethnicities? And as we go through this, what we find is there's going to be maybe a lot in one area and almost nothing in another area. So now we're going to look at, can you see me with at least 2 of these at once? So maybe it's women with polio and socioeconomic status, and then anything else that I may have overlooked or left out. So we would go through this as an example in class. I'd have people on their computers looking up, whether it's just in Google Scholar or at the library, um, how do we find something on intersectionality? And generally, what people notice is that disability is treated as the only demographic variable, and that it's very hard to find anything about maybe disability and one other demographic variable. Very often, studies on disability will mention some of these other things in the methods. They'll say participants, the median age was this, 70% were female, 85% were white, but then they don't analyze the data by different demographic groups. So I'm going to pause there and see if there are any questions about anything we've covered so far. If not, I'll go on to another activity.
We don't see any questions in the chat box at this particular time.
Okay, thank you. All right, then I'm going to go on. Everything's crystal clear so far. Good. Now I'm going to have people explore segregation. Segregation is a loaded term. People are going to have very strong emotional reactions to just using the word segregation. So I am going to have them find places in the real world where people with disabilities are separated from those without disabilities and track them throughout the week. But you do have to do some preparation for this one before you send people out to do it. So first we review the main arguments in Brown versus the Board of Education of Topeka, Kansas. Kenneth Clark was a psychologist who wrote an amicus brief to the Supreme Court talking about the dangers of segregation for Black children. So we review that. Then we talk about what is a reasonable accommodation. It's an accommodation that works, but may not be the accommodation that people with disabilities prefer. It simply has to be one that works. Then we show a documentary on segregated South or on internment of Japanese Americans during World War II, because both of these really show that segregation, once it gets codified into law and policy, really segregates people and makes them second-class citizens. Then we might have a discussion in class. When have you felt excluded? When have you felt ostracized? What gave you that feeling? What was it like for you? So we try to get to a more emotional level around segregation. And we could show, isn't it a pity, the real problem with special needs, which is a TED Talk, or you can have people watch this on their own. And it does talk about this idea of segregation for people with quote unquote special needs. So what's the goal here? The goal is to evaluate current situations that segregate people with disabilities. It might be a separate entrance that's used by people without disabilities versus people with disabilities. It might be a public transit system of trains where only some of the cars are marked with a wheelchair logo being accessible. It might be a separate bathroom or a separate stall or an eating area with accessible locations that are away from the mainstream. So the assignment has 4 steps. Spend 1 week observing and listing places that segregate people with disabilities. Analyze the rationale and the practical necessity for that segregation. Then go to or utilize that segregated area and describe your experience. And then write a 1-page report on accessibility alternatives that would minimize segregation of people with disabilities. And again, we do an example in class of 2 things. So one might be supermarkets. In supermarkets, there's often one checkout line that's designated as accessible for wheelchairs. So how is it segregated? Only one line has the wheelchair symbol and an accessible level payment machine. What's the rationale? Well, if you lowered the payment machine, that would probably make it too short for standing people. But maybe machines could be an adjustable height. What was your experience? Stood on the line at the accessible checkout, even though it was longer than other lines, resented being forced onto this line. So that's one example of the kinds of things I'm asking students to do. A second example is very different. It's about TV. And the news, I have them watch MSNBC because I want to make sure they don't watch certain other channels. And have them turn off the sound and just follow by captioning, then turn the sound on and look at the captioning and how it syncs or doesn't sync with speakers. And what they often find is it's actually hard to understand what's going on a lot of the time. So what's the rationale? Well, captioning a live show requires real-time typing, and it's hard to keep pace with the speakers. So some info is left out. And I will ask students, what kind of info got left out? And often it's names and nuances. And then what was it like? When watching by captioning alone, I felt bewildered at some portions. It was hard to tell nuance, such as joking, and it was impossible to follow if two people talked at once. Now, I do think ultimately AI is going to solve this problem for us, but it hasn't yet, and captioning is still real people typing as they go. So we go over examples in class because otherwise people are not aware that things are segregated. So it's important to go over examples to have them really understand this assignment. And you'll notice that this is an assignment that's hard to do in just 1 week. We need a week of preparation. We need a week for them to do it. And then the following week, we talk about it in class. This is a much more advanced level activity. And so in my book, I did segregate things into a more beginning level. You know, if you have 3 hours and that's it, what can you do? But if you have a little more time. So this activity is about managing fatigue due to a chronic illness or disability, to show that managing fatigue involves making choices, and that every choice to do something is a choice not to do something else. Fatigue is a huge part of many disabilities, and it is important that clinicians understand what it means in a person's life, because it's not just about managing stress, it's about managing energy all the time. So students, list all of your activities for the coming week and include everything: commuting, laundry, showering, social time, walking the dog, getting groceries, coming to school, doing homework, everything you do. And then I have a simple point system. Every household task takes 2 points, every activity outside the house, 5 points. Every hour of work is 5 points an hour. So look at everything you do in the week and total how many points you get for the whole week. If you're a cigarette smoker, you have to subtract 15 points from the total because it lowers your energy. Now, this is the hard part. Look at your list and reduce it by 20%. And after you've done that for the coming week, only do the things on your list after you've cut that 20%. And keep a record of your activities and your points and write a half-page report. I think I have, nope, I don't have a sheet. In the book, I think I have a sheet on how to keep records. Now, what happens with this assignment? Various things. Some people take it so seriously that when they run out of points on Wednesday, they call in sick to work. So now I've learned I have to tell my students, don't put your job in jeopardy. Please keep enough points to go to work every day. Some people say, I ran out of points on Wednesday, so I just stopped the assignment. And then some people who have disabilities tell me this is life-changing. I now understand how I have to live my life. So this is a very profound kind of learning experience. And I am really trying to show these potential clinicians, this is something you have to understand about your clients with disabilities. Now, everyone in the class has been assigned a disability. And so for each of those people, they have a different number of total points. So if somebody's been assigned, say, paraplegia wheelchair user, they have a different number of points than someone who was assigned to be blind. But they're often surprised that being blind also involves fatigue and all these extra things that you have to do. But you have a different number of points than someone else with a different disability. So the people who have fewer points to spend during the week find that they run out fairly quickly and they have to start making choices. If I'm going to teach this over a 15-week period, I have in the past done it where week 1, you have to cut by 10%, then week 2, you have to cut another 10%. So we do it incrementally. And then we talk about what did people cut out. And most students find that what they've cut out was socialization. That was the easiest, most expendable thing they could get rid of. And then we talk about what does it mean when you socialize less? And there are many studies showing that reduced socialization tends to lead to greater depression. And that more socialization actually leads to more longevity in life. So socialization, cutting out socialization, is not good for your mental or physical health. Let me just pause, just jump in if there was a question. If not, I'll move on to what happens. What are the outcomes?
Dr. Olkin, it doesn't look like there are any questions in the chat box just yet. However, a lot of comments saying this is very interesting. I would just love to take your class. I love these activities. So a lot of positive feedback there. But of course, if anyone has any questions, if you'd like to unmute, please also feel free to do so if that's easier.
I was wondering a quick question about this because I myself have a disability. And I'm the one who said I would just love to take your class. But for the students that already have a disability and do this at the advanced level activity, do they see a difference when they cut down like 20% off of already stuff that they have to cut out? And what are the outcomes for those students like?
Yeah, it's pretty profound. So those who already have a disability, for example, I had a student with MS who had been diagnosed within the past 5 years, and he said this changed his life because now he gets what he has to do. But sometimes people already have a disability that includes fatigue, and now I'm asking them to cut out even more in their life. And we talk about the types of things we tend to cut out. So for example, when I moved from using crutches to being in a wheelchair, when I had less energy as I aged, despite only being 29, but when I talked about how my energy decreased, I talked about how at one level there were very easy things to do. I could put scissors and pencil and paper in every room. I could have a phone in every room in the house. I could hire someone to do grocery shopping for me or use Instacart. Those are the easy things. The next level are things that are a little more meaningful. I used to do a lot of woodworking, but I found that using power tools when you don't have good stance and hand control was scary. So I stopped doing something I loved and needed to think about something else I loved that would replace that. That's a harder level. Then we get to the hardest level, which is things that I feel define who I am. I no longer give talks all across the country. I give talks by Zoom. That starts to affect how I see myself. I teach, I never teach 2 days in a row. I need a day of rest in between. It started to get at the heart of how I think of myself as a professional, a psychologist, an instructor. And we talk about those different levels, and that first level is pretty easy. That second level starts to really affect mood. That third level is very difficult. And when people get to that level, and it's the students with the disabilities who talk at that level, the other students generally are not there. It's the student, when I teach this, the students with disabilities, it's like teaching one set of students who are just talking at a whole different level than the other students. That's okay, but you need to know that so that you can kind of address both levels. Yeah. Thank you for that question. So I've been tracking outcomes a little bit of teaching this class. Everybody says they're more knowledgeable. They're more aware of able-bodied privilege because I've made them be aware of able-bodied privilege, even though there is some research that suggests that teaching people about their own privilege can actually have a backlash, that it makes them somewhat more entrenched in their own position. But I do want them to sort of have some awareness of able-bodied privilege. Why does it do that? Then most of them have thought about microaggressions that they themselves have done in the past. We've spent a fair amount of time in the class talking about microaggressions. They have a greater understanding of that term ableism. They now see it as the same as racism, in that it's our term for disability. And almost 3/4 have some specific plans to make changes for people with disabilities. All of this is the good news. What's the not so good news? Only a little more than 1/4 felt confident about how to ask a client about a disability, even though I've explicitly talked about you as a therapist need to bring up difficult topics. You need to ask people if they've been sexually abused. You need to ask people how much they drink. You need to ask them, are they a daily smoker of marijuana? There's lots of things we ask. Disability is just another thing on that list. What makes it such a taboo topic to talk about? Yet at the end of 15 weeks, more of them felt they did not feel confident about asking if they were the first to bring it up. They didn't feel confident in knowing how to ask. Only 14% said it was a little bit true that they felt confident about how to ask. 35% said they did not feel less pity. Pity is one of the things we need to be measuring because it is something that seems to be an outcome of what we're trying to do. So we need to monitor that. Even 7% felt anxious about seeing a new client using a wheelchair, and 79% felt it was true or very true that people with disabilities were inspiration. And again, this is something we've talked about inspiration porn, about the idea that we show people overcoming disability, like a guy who's paraplegic who climbs a mountain. And yet they say they're more inspired by people with disabilities. So even though it's a positive view of disability, it's still a stereotype. So there's widespread acknowledgement of learning. Most people say that the films and the YouTubes were very impactful. The textbook, they tell me the textbook Disability Affirmative Therapy was helpful in clinical skills. I'll return to that in a minute. Then this is one of my favorite quotes because I think it's so unconsciously ableist. I swear I'm not touching anything. The acknowledgement and understanding of my able-bodied privilege and how blind I've been to disability. I don't think the student heard the irony in that statement. And yet, on the weekly vignettes, they had trouble. They had trouble translating their knowledge into skills despite weekly practice. And that's the ultimate thing I'm trying to change, is those skills with disabled clients. So how should we assess what we're teaching? We need to assess both explicit and implicit bias. We have to look at both short-term outcomes and long-term outcomes. So for example, if I'm giving an activity, I might want to do some assessment of what did you get out of this activity. I might want to assess it again at the end of the class of the 15 weeks. And then again 3 months later, if I could, because it might be quite different at those 3 times. So we need a pre, an immediate post, and a long-term post. We need to assess knowledge, awareness of ableism and the issues that people with disabilities face, explicit and implicit bias, and skills. And I really want to emphasize skills. So there are various ways of assessing outcomes. Some of these are very quick. So one of them is at the end of each class, on one side of a 3x5 card, write the take-home message you got from today. Or it could be, what's one positive thing about today and what's one thing you wish had changed or had more time or been challenged about. So they can just give a 3x5 card at the end of every class. You can give an assessment of an emotional reaction, which I think I have a copy of here. Quality of life, imagined quality of life of people with disabilities. You can do an assessment of able-bodied privilege. I have measures, I have 4 questions, I have clinical vignettes. I have supervised role plays. This is something that's problematic because I have the students who actually have disabilities role play the client with a disability because they're genuine about it. And yet it's unfair to them. So I don't make them always be the client. But people with actual disabilities do things and think things and behave in certain ways that are not easy to simulate by people who don't have disabilities. An example is people in a wheelchair do micro movements to shift their position, to shift the back of the wheelchair, to move around, to move a leg, in a way that somebody who's pretending to be in a wheelchair just wouldn't think to do. And I think those things are important in these role plays. And then I have self-ratings. So let's look at some of this. But One of the things I became aware of after I had made my different outcomes was the stereo content model by Cuddy et al. The stereotype content model posits that perceptions of groups are based on two dimensions, warmth and competence, and that groups that are high in warmth but low in competence, that is by perception, not actuality, elicit pity and sympathy. And people with disabilities are generally viewed as high in warmth and low in competence. So we might need to more directly assess changes in pity and sympathy. We might need to actually highlight that in the class. So now I'm going to be making changes to my class where I'm going to talk about pity and sympathy more directly than I have in the past. So this is a scale about emotional reactions in contact with a person with a disability. And it's based on something Euchre did in the 1970s. I've changed it a little bit. And I just do a scale from 1 to 4 with no midpoint. So you got to choose. How much do you feel admiration? How much do you feel pity? How awkward, how embarrassed, how inconvenienced, how angry, how inspired, how resentful. And this is anonymous. I don't have the students' names on it because I really want them to try to think about their own responses and be honest about that. Quality of life. There are just scores and scores of assessments for quality of life. And I have distilled them down to just these areas to try to make it a shorter form that people can do. So after they've done the interview of a person with a disability, I have them fill out, what do you think is the quality of life about with this person with a disability? What is their physical and material well-being? How do you think their relationships with other people is? What about their social, community, and civic activities, their own personal development and fulfillment, and recreation? And here I'm trying to get at the difference between the perceived quality of life that non-disabled people have about people with disabilities versus the actual quality of life that people with disabilities say they have themselves. Then self-rating of attitudes and skills. This is where I get my outcomes. I feel less pity towards people with disabilities than before. 35% said no to that question. I'm more knowledgeable about at least 3 different disabilities. I have confidence. I would know how to ask about a client's disability. I would be anxious about seeing a new client using a wheelchair. I know the information in important laws relevant to people with disabilities. I could give the legal definition of disability in federal laws, such as the ADA. I'm more aware of able-bodied privilege. I feel more inspired by people with disabilities than before this class activity. I have specific plans for how to make changes for people with disabilities. I am more able to work with a client who is blind. I have reflected on microaggressions I have done towards people with disabilities in the past, and I have a greater understanding of ableism. So these are how I've measured the outcome at the end of my 15 weeks. Medical family therapy is a field that has combined working in medical settings with people with chronic illness and disabilities and family therapy. If you see my signature on my little Zoom thing, you see C/FT. It's because I'm the coordinator of the child and family track at my university. And I am a dyed-in-the-wool family therapist, even when I see individual clients. So I like to bring in some of the things from medical family therapy that I have found useful in teaching about disability. And one of them is to go over what is your culture's customs and beliefs about illness and disability. So everybody comes to their role as a clinician, having had some learning about disability and illness, even if they've never encountered it in a personal way. Like when you got the flu, did your mom say, suck it up, your temperature's down, go to school? Or did she say, let's tuck you in, I'm going to bring the TV in, I'm going to make you tea and toast? So what did you learn about illness? What causes illness? What causes mental illness? What causes genetic defects? What is the sick role? What are some home remedies that you would use? When do you seek treatment and from whom? So this is a good thing to do sort of towards the beginning of a class, to just think about what were you taught in your family and in your immediate culture around illness and disability. And then every week I do a vignette and I have them respond to questions. So I'll just read one of the sample vignettes that I have. Shannon, a divorced woman in her late 30s, requested therapy because of, quote, some disability issues that were coming up for her as time went on and she became more impaired. She has a congenital disability and thought that she had put the psychological and emotional issues behind her. But new symptoms were prompting increased contact with the medical profession and raising the possibility of surgery. Her current symptoms included frequent weeping, feelings of alienation and anxiety, and sleep disturbance. Shannon came from a family in which her father was in the military and ran the household with zero tolerance for human foibles or frailty. He was physically abusive to the mother, who was clinically depressed throughout Shannon's childhood. Both parents were active alcoholics, and Shannon's older sister started polydrug use in her early teens. So if we did this in class and we talked about it, I would show them only the first part. And in the first part, they're very focused on Shannon. And the fact that she has new symptoms and she's going to have to cope with the new symptoms and adjust to them. And I'm trying to debunk the idea that Kubler-Ross's stages of grief applies. It doesn't. People revisit their disability over and over again with each new stage in life. There's no one final level called adjustment that you miraculously reach, and then it's done. So we would talk about that. But then in the second part, when I add the second part in, it becomes much more complex. The focus now is not just about disability, but Shannon as a survivor of an upbringing that was less than optimal, and how that is going to influence how she's going to approach this new phase in her life. And now we have a much more family-oriented approach where we think about Shannon in the context of what she learned as a child, what she's introjected, what she's feeling about disability, probably some shame based on her father with a zero tolerance for human foibles. And so we show how if you're just looking at disability, it takes an outsized role, but when you put it into context, it's often a part of a much more complex picture. But my students struggle with this. When I add the second part, they get overwhelmed. They're not sure where to start. They don't know now whether they should ignore the disability. Is it still about the disability? How do they kind of treat disability within the context of a troubled background? So a couple of things to remember, and then we'll have time for questions. The stage model of response to disability has been thoroughly discredited, and yet you still hear it over and over again in the literature, that you must go through the 5 stages and that you have to grieve the loss of the normal body or the normal child who was born to you, or somehow grief must be a part of that. When in fact, studies show that depression is actually not the normative response to disability. Only about 30%, plus or minus 5%, experience depression post-diagnosis. That doesn't mean people aren't scared or anxious or sad, but a clinical depression is not the most common response. 70% do not have a clinical depression post-diagnosis. Third, disability should not be viewed as inherently pathological, but as a dimension of diversity. So remember that well-meaning is necessary, but not sufficient as a therapist. If being well-meaning was sufficient, then all of my students would do really well on the vignettes. Disability problems are personal, familial, and systemic. Therapy should not be only personal. Oh, shush. There are some issues to think about. APA has put out guidelines on treatment and assessment of people with clients with disabilities, but there's still very, very little training on this. Diversity classes give, in general, no more than 3 hours to disability. 3 hours is better than 0, but we want to make sure those 3 hours aren't just increasing sympathy and pity. Knowledge about disability and attitude change is not translating into clinical skills, which is problematic. And then something I feel is my goal, of course, is to change all of psychology, is individual attitude change is slow. We could use some broader systemic change. I actually think ARCA and the American Counseling Association are further ahead than the American Psychological Association, which has been very slow to change. We should be thinking about implicit attitudes and thinking about systemically how we might change implicit attitudes. And for our outcome measures, we don't just want to look at knowledge and awareness, we really need to look at behaviors and skills. So the 3 books I've written, the first one, What Psychotherapists Should Know About Disability, I call it Disability 101. It's a good book for people to start with in different clinical fields, but then I get much more clinical, so it's more advanced disability affirmative therapy, where I go through the 9 areas of disability affirmative therapy with lots and lots of examples, clinical examples, really trying to help clinicians understand how do we take disability and put it in the context of the whole person. And we neither make it all about the disability, nor do we ignore the disability, but we put it in the proper perspective. Like Shannon, for example, the vignette I read. And then the activities I talked about today are in teaching disability, which has 36 different activities to use in a classroom. And that brings me to the last 15 minutes, where I would love to take questions, hear comments, thoughts.
Thank you so much, Dr. Olkin. So we do have one question in the chat. Any tips, suggestions, thoughts on considerations for when teaching a course totally virtually?
Yes, actually, I have taught this virtually and I've taught it in person. One of the biggest differences, of course, is you see me now and I don't look like I have any disability versus when I'm in person, there I am in my wheelchair. Good and bad. Virtually, people are slightly more able to say things to me that they feel awkward saying to me when they see me. They don't want to insult me, which is why I use the 3x5 cards to give feedback anonymously. Um, it is okay to teach this virtually. And I'm assuming most people are not people with visible disabilities who are going to be teaching this, but I use so many different first person accounts and YouTubes with people with disabilities that they do see disability all through the class in films and YouTubes and everywhere. And then they do the interview with a person with a disability. So I don't think you're at a great disadvantage teaching this online, other than all of the disadvantages that we all have found teaching online. People don't have an attention span for a 3-hour class. It's harder to do role plays. Um, they all put themselves on mute and nobody wants to talk. So it's the usual kinds of disadvantages, but I don't think it's a disadvantage that's specific to this class.
Thank you. Now, we do have a few requests. If you're willing to share your PowerPoint, that would be very much appreciated.
Absolutely. I have already sent that to Daniel.
Wonderful. And by the way, I'm Christine Sacco-Benny. I'm one of the other board members who works with Daniel. It's a pleasure to be here. Thank you so much.
Thank you.
And you're welcome. Another question we have, what are some of the common challenges that educators face when teaching disability as diversity, and how might they be addressed within the system?
As I said earlier, one disadvantage is that it's often people who don't have lived experience with disabilities who do have to teach this. And it is very, very hard to teach about demographics that you don't have good familiarity with. Secondly, student evaluations for diversity classes are generally lower than for other classes. You get more pushback, you get more, I don't want to call it hazing, but you get more argumentative responses sometimes in these classes. I think they're hard classes for people to teach. I think that we are starting to learn empirically driven methods for teaching about diversity. And some of that contradicts what we have believed. So, for example, teaching people about privilege sometimes leads to a backlash. Whereas I think lots of diversity classes start by helping people be aware of their own level of privilege. So I think these are some of the difficulties of teaching about it. And third, the people who take the class, which is an elective, not a mandatory class, are already halfway there because they've elected to take the class. It's the people who don't take the class that we most need to reach. And this is why I start thinking about what could we be doing systemically that might affect everyone and not just people who get to take a 15-week class in disability. And in my program, we actually are very fortunate. We have 2 people with lived experience, and the other person teaches Disability 101. What are the laws? What is change for people with disabilities? What does it mean to be accessible? And then I get to teach about it clinically. Most places don't have that and are never going to have that. And so that's a big challenge about how we make that available to more people. And then the other big issue for me is that rehab psychology has been traditionally a white male straight field. When I went to my very first meeting of rehab psych, I was the only visibly disabled person in the room, and it startled me. It's the one area where we don't expect the people with lived experiences to be the experts. We have an Asian American Psych Association, we have a Black and African American Psych Association, we have an LGBTQ subdivision, and yet you look at rehab psych within psychology, and it isn't, until very recently, it wasn't people with disabilities. Now, I do want to make you aware of a very important networking opportunity. It's called DARN, DARN, and it's Disability Advocacy and Research Network. And to join, it's darndisability.org. So that is academics, clinicians, researchers in all fields. It's interdisciplinary. And this is where people go for support. This is where people go for help with research. This is where people go to talk about clinical issues. It's an incredible group of approximately 600 people, many of whom have disabilities themselves. And it's not done in psychology. It's just an offshoot. It was started by Kathleen Bogart, who's at the Oregon State University and has been a good researcher in social psychology of disability. So if you're at all interested, I really encourage you to join that. What was the website? Let me put it in.
I think I was able to do that on darndisability.org. Is that correct?
Thank you very much. You
Beautiful.
beat me to it.
No, it takes all sorts of fingers on the keyboard when they need to. All right. So we have another question. I'm a year one clinical mental health counselor and hope my population with people with disabilities. My university doesn't have a disability studies with the mental health concentration. Do you have any considerations or suggestions to learn and become that would help me to learn and become more knowledgeable?
With all due respect, I wrote the 3 books exactly for you. That is exactly who I'm trying to reach, are the people who really don't have the background. And clinically, I think disability affirmative therapy is the one for clinicians, because some of the thinking that I have in the first book, I developed much more fully in the second book, Disability Affirmative Therapy. And then taking workshops like this series that you have done, starting to understand the complexity, I think, is actually one of the first steps. It's not to go from not knowledgeable to knowledgeable, but from knowledgeable to knowledgeable about all I don't know and need to learn about. And then to realize it takes a long time to have any kind of expertise in something in which you don't have personal familiarity. You know, we used to think we had to be culturally competent across all cultures, and now we think you can maybe master 2 to 3 cultures at best, and you're just not going to be expert in everything. So those would be my suggestions.
That was mine, and I do have lived experience. I have seizures every day, and so I was like, but I wanted to have more for all of them because of my population. I really want to help with people with disability because I'm also one. So yeah.
And just because I have a disability doesn't mean I'm knowledgeable about all disabilities.
Yeah,
So
I was like, so how do I become all of them? Yeah.
right. Like, you know, when I'm thinking about, is my website accessible to people who are blind, I have to talk to an expert on that because I just don't know how to understand that. Yeah.
And I have bought 2 of your books. Like while you were talking, I was like, where are her books?
That is my favorite sentence in the English language. Also, it was very helpful that you kept nodding at me during the talk, so that was great.
Oh, yeah.
I see there's a question about the appalling lack of research done with people who actually have disabilities. It's people it's psychologists and disability that's had an appalling lack of research. And in the research on disability, it's mostly done by people who don't have disabilities. It
Right.
is only in the last few years that federal funding agencies, when they review your grant, actually give you points if you have lived experience of disability. So that's brand new. It's just beginning to change.
It's also that way in the counseling realm. There is very little in the counseling literature that talks about counselors working with people with disabilities. And then if you get disability specific, there's even less. So as I said, this is a topic that's near and dear to my heart. And I've used your work in some of my research, so thank you very much. But yeah, my dissertation is centered around this topic and people with brain injuries, as a matter of fact.
So one of my articles was titled "Disability is the Caboose on the Diversity Train." And what I'm saying there is Martin Luther King said, a rising tide raises all boats.
Mhm.
And it's not true. I have had to look at all of the research on women, on race, on LGBTQ, and say, okay, now let's apply this here. It
Mhm.
doesn't equally lift all boats.
No.
And we have to do disability specifically to lift that boat.
Yeah, I agree.
Thank you. Any other questions? All right, I had one come to me. How can institutions better support faculty in integrating disability as diversity in their teaching practice?
Excellent question. Right now, what happens is all minority statuses are pitted against each other. You have X amount of time, you have certain required courses, you don't have a lot of room for electives, you have one diversity class, fit everything in. Every moment spent on disability is a moment spent on something, not spent on something else. That pits us against each other. We have to start teaching not about individual conditions. We have to teach about intersectionality. We have to infuse it into every different class. There has to be academic administration support for upgrading our programs where we get work time, workload for doing this. There has to be a line item in the budget for faculty and staff with disabilities. There is for students, not for faculty and staff. We have to go over our catalogs and our program information, and we have to put disability awareness front and center. We have to teach faculty that when you read your syllabus out loud to students on day one, if you read out loud the part about disability accommodations, more students divulge their disability than if you don't read it. So there are many things we can do systemically, but we haven't done them.
Thank you. All right, I want to make sure that I give some space and time. If anybody else has questions. All right, I had one more question that came to me. How can the allied mental health professions better assess the impact of teaching disability as diversity on students, new employees, and new professionals' attitudes and behaviors?
So you have some measures that I've included in my talk. I think if we start including vignettes every time we're teaching clinical material, and some of those vignettes have people with disabilities, that's the way we're going to infuse it everywhere and start to assess how students and new professionals are doing in terms of thinking about disability. If we also could get even 2 questions on licensing exams about disability, it would actually show that we as a field are taking it seriously and that people need to learn about this, and it would infuse it from the top down as well as from the bottom up.
Thank you.
There are no questions about disabilities on the exam.
None.
Okay.
I really want to thank you all for inviting me today. This has been great to see this audience of interested people. I really appreciate it.
Oh, and we want to extend our sincerest gratitude to you for this incredible workshop. We've had so many comments and accolades, how much folks have really appreciated this. For those in attendance this afternoon, this actually concludes. This was our big presentation webinar. This concludes our June month-long webinar series, as well as our monthly 2023 to 24 ARCA Webinar Series. We appreciate you joining us, and we are most grateful for your support. I would like to take just a moment to thank a few folks. Vicki Leeming, who is our office administrator, has been instrumental in being part of this and making sure that you all get your CEs as part of this. Truly appreciate her, as well as Dr. Taryn Richardson and our student representative, Alexis Dugan. For those of you interested, our new board starts July 1, and we encourage active involvement and would love to invite folks to come back to present and to be part of our organization. Dr. Olkin, thank you so much. Truly a pleasure.
Thank you. Bye, everyone.